Good morning, everyone. I am Yuping Cheng, the Associate Dean for Research and Scholarship here at School of Nursing. I would like to welcome you all to the University of Buffalo School of Nursing's 8th Annual Research Day and 24th Annual Bonnie Bullough Lecture. This event has been made possible through generous support from the Margaret A. Nelson and Bonnie Bullough Endowment Fund. I would also like to thank our poster award sponsors, the Gamma Kappa chapter of our Nursing Honors Society, Sigma Theta Tau International, and the Alan Volpe Memorial Fund for supporting the event by providing monetary awards for our poster competition. This year's presentation topic of digital health technology for behavioral change and symptom management has never been so relevant. Throughout the COVID-19 pandemic, there has been a growing reliance on the use of technology to not only learn, live, and stay connected, but to also access and manage the care for our health. Today's event will begin with our keynote presentation and will be followed by the poster presentation section. We have 41 wonderful posters this year, being presented by students, faculty, and community partners. We will conclude our event by announcing poster award winners. So now, I would like to turn the stage over to the Deans of the School of Nursing to deliver her welcome remarks and to introduce our keynote speaker. Please join me in welcoming Dr. Marshall Lewis.
Thank you so much, Dr. Cheng, for the introduction. And good morning, everyone. Thank you for joining us today. While we can't get together in person, we are so pleased to see this wonderful turnout for our annual Research Day and Keynote Lecture. We have over 250 registrations. We're honored today to present Dr. Ryan Shaw as our 24th annual Bonnie Bullough Lecturer. Dr. Shaw is an associate professor and digital health scientist at Duke University School of Nursing and the Duke Center for Applied Genomics and Precision Medicine. He has collaborative appointments at the Duke Center for Health Informatics and MEDEX, Duke's Medicine and Engineering Initiative. He is also the Elizabeth C. Clipp Term Chair of Nursing, Faculty Director of Duke's Mobile App Gateway, and the creator and director of the school's Health Innovation Lab. Dr. Shaw works with faculty, staff, and students at Duke School of Nursing, Medicine, and Engineering to integrate mobile technologies into first-generation care delivery systems. He was one of the first scientists to publish that patients could feasibly use multiple mobile technologies to manage their health. Dr. Shaw has also conducted foundational clinical trials to explore how patients and clinicians use mobile health for self-management and care delivery. Dr. Shaw is widely published and has presented on health technologies topics, both nationally and internationally. Before we begin, I would like to give you just a couple of housekeeping tips. Please remain muted throughout the duration of the presentation. There will be about 15 minutes for questions at the end of the presentation. You may submit your questions through the chat during our presentation. Now, let us turn to our keynote lecture. Welcome, Dr. Shaw, and thank you for joining us today.
Well, thank you so much. Thank you, Dean Lewis, and also thank you to Dr. Cheng for this invitation. All right, just gonna share my screen real quick. Let's get this together. All right. So I'm excited to speak with you about digital health technologies for behavior change and symptom management. If you're curious and if you've never seen this before, this is a FDA FDA cleared 6-lead electrocardiogram that connects to your phone. A lot has changed since I started nursing about 18 years ago. So I'm going to start here. these are our patients. They are connected. And it's not just younger people, it's increasingly older adults too. In recent statistics from the Pew Foundation, these just came out last Monday, actually shows that the US adult population is more connected than ever. Most people own at least a basic cell phone, and this transcends rural, urban, and socioeconomic backgrounds. Increasingly, people own a smartphone too. Over 85% of the entire US adult population owns a smartphone. In other words, people are walking around with this computer in their pocket, and the really important thing about that is that it really enables direct reach from people, more attuned to where health usually occurs, which is not usually in a clinic or in the hospital. It happens throughout our lives. And increasingly, people have in-home broadband too, over 3/4. Now, I realize this isn't everybody, and there are disparities here in who has access and also affordability here. But nevertheless, from a healthcare delivery standpoint, you can't deny that there is opportunity here to collect health data from patients. And so when we think about health data, I think about it in terms of being able to maybe deliver surveys. People could complete that on their phone, could be through a patient portal in the electronic health record. We can also collect data from sensors that might be embedded in the device. There's also connected devices. We think about wearables like Apple Watch, Fitbit, Garmin. There's also there's also blood pressure cuffs, glucometers. There's that 6-lead EKG, and there's increasingly in-home devices too. In other words, AI is increasingly coming into people's home, and these things are surprisingly affordable too. And we also have environmental sensors too, and that's probably used a bit less right now, but we can, for the most part, begin to capture data on the temperature, the particulate matter, and so forth, really in the environments where our patients live. This can get complex, and this is just to glance at it, that within your phone, there's an incredible amount of really data types that we can begin to generate and begin to collect. It's quite surprising what all you can do here. And this includes apps too, which we're all familiar with. We have things like these single lead EKGs. This has been out from Apple for a few years now, and there are other companies too. If you've never tried this, I would really recommend it. It does work. It's not the easiest thing to use, but it does work, and it is FDA cleared too. And then we also have these 6-lead EKGs too. And it's not necessarily that these have been used yet, but you can imagine that previously a patient would have to come into the clinic for us to be able to capture data like this. But if we can begin to capture high quality data like this from patients, we can begin to conceptualize new ways that we might be able to deliver care, particularly for people in maybe rural areas where we don't have to keep asking people to come back in. And one of the main things here is that we are better able to capture health data over time, not just in these discrete time points when people come into the clinic or they come into the hospital, but it's really this idea that we are almost democratizing health data to meet people again where health usually happens. And people can get really creative about this. This is one of the earlier apps, and it's called Autism and Beyond. And what this was is it was essentially you download this app, and you play this video for a child, and based upon their reactions to it, the AI would essentially, or what it does is it will analyze the facial expressions there. If there's a likelihood that they then need to be screened for autism. This is not diagnostic, but we can get really creative with the ways in which we might create the ways in which we might try to capture data for different care delivery models. So when I think about digital health, this is a definition from HIMSS, and they say that digital health connects, empowers people and populations to manage health and wellness, augmented by supportive provider teams to create what's called these digitally enabled care environments. And the goal here is to leverage digital tools to transform care delivery. And so what the promise is here is that digital health can allow us to collect patient-generated health data to hopefully continuously measure manifestations of different diseases and also illnesses. And hopefully we can pull these data into, say, an electronic health record so that we can continue to use them we can also begin to characterize the frequency, length, and the content of patient symptoms. And what we are attempting to do is to be able to see early manifestations and maybe even predict when people might have problems, and also also be able to create more prompt interventions. So here's this is a model that I like to go by from Gambier. And if we start in the upper left-hand corner, we can begin to think about how we might collect these patient-generated health data from patients across the lifespan, from birth even all the way towards death, right? And if we can tailor the monitoring to be customized towards the individual and their family or to their caregivers, and we can pull these data back into the system, whether that's the health system, the clinic, through some health portal, we can then analyze it in a feedback loop. And that feedback loop could be to the providers, it could be to nurses, to doctors. We can begin to look at pattern recognition, apply data science techniques to that. And then we can send a response back to patients to give them more insight into their own health. We can give them prompts, cues to action, to make changes. And on the clinical side, hopefully have more insight into the health of patients and also populations. So we are in a changing healthcare landscape. A lot has changed in this past year. And needless to say, COVID-19 has had a huge impact in this area in the digital health area. But in particular, there's been this growing focus on delivering telehealth. If you remember about a year ago now, it's April 16th, we were really you could almost call it super lockdown. And all of a sudden, the clinics and also hospitals were rushing to deliver telehealth. And essentially, they took clinic care and moved it into video care. into phone care too. And I've also heard from physicians all over the country that they never delivered telehealth prior to COVID. I've heard from health systems all over the country that they had to shift the nursing workforce over to delivering telehealth, and really quickly too. And essentially, health systems that were set up to be able to do this have fared a lot better. Now, that spike in the telehealth delivery has definitely come back down. We're now back to delivering in-person care, but nevertheless, it's here to stay. And with the COVID-19 public health emergency, CMS waived what they did is that they had waived limitations on reimbursement. Thus, there's a business model here, and that's one of the key things. Now, and it's still to be determined how much of that is going to be sustained, but that's for the politicians to decide there. And the CARES Act of 2020 also provided funding to help providers to deliver telehealth services. And I imagine many of you here may have also experienced telehealth for the first time this past year. And it can be particularly good, especially for mental health-based services. You don't necessarily have to be physically in the same room. And it may be useful also for chronic disease-based care, where we don't necessarily need to always physically be in the same room. We're also seeing some more creative type models come forward too. These hospital at-home programs are really growing all over the country. These began prior to the pandemic, and some of the two big players at the time were Contessa Health and also Brigham. And essentially what happens is, say, you might have a patient come into the emergency department who has congestive heart failure, and instead of keeping them in the hospital overnight, they might be discharged home instead, in which they will receive this suite of these remote monitoring technologies that might be, say, tethered to this iPad with a cellular connection. A nurse will remotely monitor them, and they will even go into their home to draw labs, to take vital signs. They might send might also send the physician into the home too. And so we are seeing these technologies be used in new care delivery models in this way. In February of 2020, I started talking about Amazon Care, and this is where essentially, if you are an employee, you can download this app onto your phone. You can speak with a nurse via video. You can speak with a nurse, a practitioner. You can have 24/7 chat. The nurse will come into your home to take vital signs, to draw labs. And at the time, it almost seemed like, wow, this is kind of futuristic. Will this take off or not? But then when COVID hit, I mean, these kind of tools and this really structure of the way to deliver care really grew. And this is big business now. There are companies all over the country that are beginning to deliver care in this way. Think like Walmart. And we see companies like Livongo, which was recently bought for over $1 billion, to companies called that are called One a medical, and it's the same model too. And so this is not to sell Amazon here at all. I have nothing to do with them. But the idea here is that this is going to become what healthcare is like. And I think the more interesting thing is that for many years, we were concerned that, technology would make healthcare cold. It would make nursing care cold. No one wants to be cared for by a robot. But actually, it's bringing people into your home. So the nurse might come into your house, which could be really good, because a lot of patients don't want to go into the hospital, but it may also help us be able to better determine different social influencers of health too. Now, this is a lot of different opportunity, but there are a lot of different challenges too. Certainly around privacy and security, and with regulations too. And I'm not going to talk too much about this because we don't have too much time. And there's also challenges around equity. There's still a digital divide. People also have to be able to use tools. If you have dexterity challenges, if you have poor eyesight, we can't use these tools for everybody, but we can get creative in thinking about how we might. We also need to design these for diverse communities. They need to be usable by people too. These are still often designed by young people, and they are tested on younger people too, which aren't necessarily most of the patients who also might be sick, and also technical literacy too. So while there is a lot of different opportunity, we do still have challenges. Nevertheless, there is research going on that will help guide us to understand how to help guide us to understand how to leverage these for care delivery. And there is research on this going on all over the country, all over the world too. So I'm just going to show you some examples of the work that we have been doing here in my lab across the lifespan. So this is my former PhD student, Dr. Jackie Vaughn, and she does work with pediatric patients, and in this case, it's in the inpatient setting. These children are undergoing a bone marrow transplant, and she gives them this. They receive this package here. They have to be big enough to wear this Apple Watch, and they can either download the app, or they receive a iPad, and both the children and their family members, they will essentially report symptoms using the app, and it includes things like it includes things like asking if they are having pain. They use emojis too, which children tend to really like. I like emojis too. And so what this does is it really allows us to get better insight into the symptoms that these kids are essentially having as they go throughout the as they go out this transplant process. But it's not just inpatient though. When they are discharged, they can go home with these tools too, so that we can continue to monitor and to capture data from them. And here's just one example of the ways in which we might use data from these tools to get better insight into their health. You can see at the bottom of this graph here, these are clinical events such as when the child underwent transplant to when they were discharged, and we can see that their step count had gone up. They were more active prior to discharge. Their heart rate also had gone down. And the goal here is that we don't stop monitoring them when they go home. We can better follow them throughout their care journey here. And there are many ways in which we might display these and really how these data might be displayed too. And that can take different expertise, which I don't necessarily have. We can look at it within pie charts to kind of have a better understanding of the symptoms that they had. Now, how useful this is, that's for really you to determine. Not all of these are that useful, but we have to kind of explore the ways in which we might be able to use these for clinical decision support. At one point in time, we thought it would be great if we could do symptom maps. For example, sounded like a great idea, but it found out that clinicians and patients, they didn't really like this kind of visualization. They weren't really sure what to do with it. And so it's always, this is why it's really important to also do qualitative based work to really gain insight into your approaches and to ask more questions too. So that's just one example with the pediatric population. This is an ongoing study called Log to Lose. And in Log to Lose, we are essentially attempting to use technology to persuade people to maintain their weight loss behaviors. This is an ongoing 18-month trial where we are enrolling 700 we are enrolling 700 participants into a 4-arm randomized controlled trial. And essentially what we are doing here is we pull in data from a diet app and from a wireless scale. And as these participants go through this 6-month weight loss trial, we leverage that data in near real time in this feedback loop, so that every week we are messaging them to tell them if they had lost weight, if they had also tracked diet, and they get this variable reward every week. They can get paid between $2 and $20. And it's not really about the money there. It's about this data flow that we are able to give feedback to people in their everyday environments as they are having to make these, or as they are having to make these daily decisions about their behaviors. And so in our previous work, we had shown that this does work. It is feasible to capture data, and so we have expanded this now to a large randomized controlled trial. And the idea here is that we can translate this into other models too. So perhaps people could get coupons, or they could get discounts on things. Maybe this could be for employers, and to begin to reward people for doing good behavior change. Now, this is very oversimplified. These things get quite complex, and you just don't get the data and send it back. You really have to engineer these data models. And I'm not going to go into too much detail here, but you essentially have to figure out how to capture that data, put it in a database, and then you apply algorithms to it. And then you can do this feedback loop, which could be to patients, could be to clinicians too. So here's another example. This study is called Partnered to Lose. And in this case, we are looking at if people are more likely to lose weight if their spouse is involved or their partner is involved here. And so this is a 24-month trial. Again, they go through this proven weight loss program. So we're not really discovering how to get people to lose weight. We are trying to help them to maintain healthy behaviors over time, which I think is really one of the big benefits of being able to use technology, is that we can both automate it, but we can also scale it a lot easier, because there's no way that we can begin to deliver these interventions to thousands and to even millions like we traditionally did. And you don't necessarily need sophisticated software to do this. You can even use things like Redcap, which I had Googled that you all have this also at Buffalo. And essentially, we use Redcap to essentially we are using it to automate the message delivery and the interaction over 2 years. And this is really important because we don't have the staff resources to send messages to hundreds of people. We would have to do it every day at the exact same time. So we can leverage software here really for scalability and for affordability too. So we have also been able to do this with multiple devices. This study was called Diabetes Mobile Care, funded by the National Institute of Nursing Research. And in this case, we were trying to determine for one, could we enroll real patients? And when I say real, patients from our primary care clinics here from the Durham, North Carolina, from the area here. And is there a way in which we could get them to collect data and send it to us? So I gave them a wireless glucometer, a activity tracker, and a cellular cellular scale, with the goal that they would use these to self-manage their own diabetes. And one of the keys here is that we did not require in-home internet. Because if you remember from those statistics from the beginning, most people own at least a smartphone, right? But not everybody has in-home broadband. So if we can meet people where they are likely to use these devices, even for managing complex chronic illnesses like diabetes. And this is just to show you. I know this is a busy slide. Is that even though for this study we recruited just 60 participants, we were able to enroll a mostly Black population, people from different socio-economic backgrounds, but we can engage patients to be able to do this. And I will show you some of that too. So in the diabetes mobile care study, we were able to pull data back, and we were able to get patients to track data for at least 6 months. And we were able to do pattern recognition within the data that we had received. And since this was a mixed methods study, we also did interviews with the patients to begin to understand how begin to understand how we might give the data back to them. in which they said that they want simplistic visualizations that say good versus bad, because you can imagine giving people several devices. There's a lot of these data that get generated, and so however, there are still challenges with the data transmission, data quality, and reliability. So one thing that we were able to do is just by not even looking at the actual data values, but whether or not people transmit data or not, we can classify them into different groups. And we were able to classify people into those who did transmit data, which we would call high responders, and then those who were low responders. And the interesting thing here was that those who did not transmit data much over time tended to be sicker patients. They had higher hemoglobin A1Cs, and they tended to be younger too, which people pushed back on me at first, saying, "Oh, there's no way that the young people are not going to use these devices. It's going to be likely the older adults." But that was not the case. We were able to teach people how to use these. It just happens to be that if you're 22 and you have type 2 diabetes and a really high hemoglobin A1C, there's probably a lot going on in your life. And so the idea there is that maybe they need more services for their health. Some other things is that there are also data quality challenges too. This is from the wireless scale. And you can see that for the most part, it's the same data pattern over time, but we get these anomalies in the data where all of a sudden it's like 30 pounds less. And sometimes it's even more than this. Like someone has all of a sudden lost 150 pounds when they step on that scale. Well, it's likely a family member, right? Spouse, kid, someone else stepped on it. Because we don't 100% know who stepped on that scale. People always ask, can we get a biometric scale? Well, these things get expensive, so not quite. So we get this data no matter what. So we had to figure out what data we might just throw out, if you will, because it doesn't make sense. But also, there's only a certain amount of the insight you can get from every single data point. So you have to kind of figure that out too. It's also important for us to figure out how we're going to display this data. So let me explain this one to you. This is the glucose data from the glucometer from the company that we were getting this from. And in this case, the patients were tracking before breakfast, after breakfast, lunch, and dinner. And you end up getting a lot of data here. And it was just a bunch of dots, to be honest. And so we kind of put all of those trajectories together. And then we overlaid the hemoglobin A1C level from the electronic health record. And the trend does kind of match. But is this useful or not is a whole nother story. And so being able to present data and to visualize it, there's a lot of work to be done here. And I quickly realized that I don't have this expertise, and then I have to team up with people that do. So this is work from one of my current PhD students, Anya Diane, and she's examining how we might further tailor digital health interventions for Black men that have type 2 diabetes. And the goal here is she's trying to figure out how they might be able to use these tools for self management. What are the barriers? What are the facilitators? But then also, once we get that data, how do we give it back to them so that they can be empowered to self-manage? And the ultimate goal is that we would pull data from these devices into the electronic health record, so that we can begin to create more tailored care delivery models for this population. So, sorry. This is a newly funded grant called the Extend Trial for expanding technology-enabled chronic disease care, also funded by the National Institute for Nursing Research. And the goal here is that we're taking previous work where we have essentially been able to say that we can get patients to use multiple monitoring devices. And with the evidence that we also currently have on using telehealth, and can we take that to the next level to be integrated within a health system's care delivery model. And so this study is also combining team-based telehealth with mobile monitoring. And we are specifically targeting patients who have multiple chronic illnesses, in this case, uncontrolled diabetes, and also uncontrolled and also hypertension. And this is particularly complex to manage in the sense that having these patients come into the clinic every 3 to 6 months, it's just not enough. They really need more care. They need to be engaged more. And we need more data and information as to really what is happening in between office visits. And so we are enrolling 220 patients from primary care and endocrine clinics here. And so in this 2-arm randomized controlled trial, everybody's going to be receiving this suite of these remote monitoring technologies, similar to before, except this time we also get a blood pressure device. And what people often say is, wow, they're getting a lot. Well, for these chronic diseases, it's a lot to manage. And there's beyond this activity tracker, they're already being asked to manage the other data too. And so there is a lot going on here. And so what's going to happen is that people are going to be randomized to receive this suite of these tools, and we'll be pulling we will be pulling data from these tools back into our electronic health record, with the goal to empower them to self-manage, right? In that we are also hoping to use these data to do things like maybe a predictive analytics. And then in the other arm of the randomized controlled trial, we enroll people into this telehealth care delivery in this model, which is really nurse-led. And in our previous work, we have also shown that nurse-led telehealth by itself really does help this patient population to reduce their hemoglobin A1C and so in this one, a nurse is essentially teaming up with a pharmacist to deliver bi-weekly telehealth. So the nurse calls them up on the phone to deliver a video visit. They review the data from all of those different, from those 4 devices, and they deliver self-management modules about a medication and also about managing diabetes. They compile the report in the electronic health record, and they send it to the pharmacist. And the pharmacist titrates their medications. And the idea here is that in between these office visits, we can hopefully improve the patient's health outcomes. Hemoglobin A1C, blood pressure, their management and so forth. And so these patients will be in this intervention for a year, and then we will do a 1-year follow-up. We are also looking at how we might implement this within the larger health system and how this might be scaled. So we use interviews to do that with patients, clinicians. We are also looking at really how much something like this will, cost compared to the reimbursement mechanisms. We have a health economist on our team. And I think one of the most interesting things is that if we can get these data from these multiple devices, and if we can combine that with data in the electronic health record, we can find signal from within these data to hopefully predict clinical events, right? So if these patients come in, say, to the emergency department or into urgent care, it is very unlikely that we will have seen some pattern prior to that within the data that perhaps a nurse or maybe someone else could have just called them up to come in, or they could have done some virtual-based visit to hopefully mitigate those worsening outcomes. And so nursing science is really important, and it's very critical that we invest in science, because we can begin to identify symptom trajectories. We can look at patterns. We can look at symptom clusters. This is what nurses do, and we can begin to characterize phenotypes, right? Where we can begin to classify patients who might might have worsening symptoms, who might need more care, or really different ways that we might tailor care. And what these technologies can do is to really illuminate more of the biology that might underlying symptoms. So in summary, healthcare is evolving, and it really has been accelerated by COVID-19. There's this big transition, right, from moving to not only to deliver care remotely, but to deliver a better care that isn't quite so episodic in nature too, because health is not episodic, it is ongoing, right? And we are witnessing the implementation of novel care delivery models. And digital health is opportunity really to enhance care delivery, improve health outcomes, and hopefully provide more equitable and accessible care, if we can get this right. There are still so many challenges. Long-term health outcomes. It's hard to know if these tools are going to improve, long-term health until we do these studies. Yet technology evolves really quickly, and that is a big challenge. There's also challenges with accessibility. This needs to work for diverse populations, technical literacy. How do we visualize and also give back complex, time-intensive data? There's also issues around security, privacy, and more. Just can talk about everything today. And one of the key things that I like to tell everybody is that technology changes fast. So don't focus so much on the actual tech. Focus on the data in the care delivery models, right? Because the core data is likely never to change. Blood pressure, heart rate, right? Those things we're still going to collect. There's just new ways in which we might be able to. I have many people to acknowledge for this work. My staff, students, faculty, many people. This stuff does not happen in a silo. It really takes teams. So here's some references. You are more than welcome to go back and to look at these. Right. Yeah. Thank you very much.
Thank you very much, Dr. Shaw. This is a wonderful presentation. We have some time for question and discussion. So there's a question in the chat box, Dr. Shaw. From a clinical research standpoint, using technology-assisted delivery of an intervention, what is the best way to tease out the assessment of data versus delivery of intervention? And do we consider a unique research design specific to this framework of research?
I'm gonna, hold on, let me bring that up. That was a, I'm gonna bring up the chat box so I can see this. Sorry, it was from clinical research. So, assessment of data versus delivery of intervention. I guess I'm trying to understand the question here. So to tease out the assessment of the data versus delivery of an intervention.
Or maybe Tanya, are you in the audience?
Yeah.
Would you mind just asking the question?
Yes, thank you so much, Dr. Shaw. Wonderful presentation. I think based from the interactiveness nature of this modality and this technology assisted, it is sometimes challenging to really clearly identify what is the independent variable that you're interested in. And I appreciate your comment that talked about, you know, the degree to which patients respond to the survey itself can be an independent variable of focus, you know, the level of engagement, I guess, and then the outcome. So it seems like there's just so many variables to consider, to lay out and to tease out. Sometimes, you know, for example, in my research focus of delivering mindfulness-based stress reduction delivery, you know, I can see the potential benefit of maintaining the healthy behavior over time and the scalability of it. I mean, there's so many apps out there, but I feel like there are specific key, critical, important questions that we need to ask using this technology to really best serve the patient. I hope that's a little bit clear.
It is, yes. And you know, I also skimmed over a lot of stuff, right? I didn't have time to go into you know, detail on really most things. Yeah. So I always focus on really designing interventions first. I don't even think about the technology, right? I think about, you know, what do we need to do for this, for the a population? And then I think about what is the data that we need, and when do we need that data, right? And then I think about what technology might allow me to capture that health data or that information along this timeline that we are looking to do. So if it's, say, mindfulness, right? The idea is when people might need to do a mindfulness, right? And when might I want to capture information about when they are doing it, or how often they might engage with it, or when are the outcomes that I'm trying to assess then. So that's how I tend to think about it, and I also try to simplify it as much as possible. I'll be honest, I use text messaging more than anything else because that's what most people use to. It keeps it a bit simple, and so that's how I think about it. Did that help? Did that answer your question?
It does. It does. You know, I think that's a key question, is to really be clear. What are you asking? Because you can get down the rabbit hole and muddy things up very quickly with technology. Like you said, you know, there's so much data to look at, but, you know, what is the best way to present it that it's meaningful to people and helpful?
Yeah. And, you know, also to your point, I would say technology actually in and of itself doesn't improve health. It's just a thing. We have to meet people at the very last point to change behavior. And that is really theoretical based. That is where the science really comes into play, because we have to deliver content. It has to be the correct content, the right timing. And so that's really the key there. It's really less about the technology and really about the data, right? And so.
Thank you.
Yeah. Thanks.
Great. Dr. Shaw, there's another question posted from Meg. Can you expand upon the creation of your apps?
Yeah.
And your partnership with technology experts?
Yeah. So in the early days, if you will, and this was just 10 years ago, I used to have to pretty much develop all of the software on my own. I had to hire software developers. But there are companies now that you can partner with, and they will offer this as a service. So we don't have to keep building software now. Things have changed a lot, and it's a lot more affordable now too. So I would actually recommend to people, don't keep reinventing the wheel. There are better opportunities now where we can get contracts with companies that essentially host these software platforms, and you have your individual instance of this app of theirs that they might download, and it's just your study, and it's almost like a temporary thing, similar to how Redcap is, right? It's a pre-built. It's now a pre-built, and we can leverage that technology because these are expensive to build at first. So that's it. So the app about the autism and beyond, I didn't create that specific one. That was created here at Duke. But in terms of the psychometric testing, so when I send patients surveys, I really always try to use valid instruments. We might have to modify them for that specific population. But for the most part, I try not to use things that aren't validated. If we use devices, they need to be FDA cleared, or I at least try to find literature online to show that they are reliable. So I'm often juggling between a traditional measure that you might think of, right, versus a device or something that might capture some, that might capture this health data.
Great, thank you. There's another question from Christina De Rosa. She is interested in knowing, do you see mobile health as being able to address health holistically, combining some of the tracking and intervention apps currently being developed to manage multiple chronic illnesses, for example?
Yeah, so I really feel that digital health has a lot of, is really going to have a positive impact, particularly with complex chronic illnesses, right? And the main reason is that these are things that people live with in their everyday lives that essentially often manifest over years, and people will deal with them for decades, right? And so what these technologies allow us to do is to be able to get health information people really over time, and to get better insight into what is really going on. Because coming into the clinic or to a hospital every 6 months, it's not enough, right? And so that's really the goal there, is to be able to gain better insight from people on their health, and to be able to transform care delivery to meet their needs, right? So we can capture data from people, and there's no reason now where we can't actually go to people to deliver care, and not necessarily digitally, but in person too. And so it really is almost it's a complete redesign of how we traditionally think about brick and mortar healthcare. We're going to be building less hospitals. We can just go into people's homes too. So.
Great, thank you. The next question is from Mike Spacker. Do you see these technologies having an impact on the role of the nurse in our healthcare system? And if so, how?
Absolutely. Yeah. I think nursing is going to be impacted by these technologies probably more so than any other profession. And the reason why is nurses were already, capturing data using various technologies. I was an ICU nurse back in the past. I've worked in cardiac surgery, and it was essentially my role to, monitor patients, to take care of them, to capture data from them. So in some ways, that inpatient model there is moving to the outpatient setting for population health too. And so who's going to be taking care of all of this data management? Who's going to be really having these maybe even day-to-day, interactions with patients like this? It's going to be nurses, and it fits within our scope of practice too. So I think there's going to be a growing job market too for nurses to be delivering remote care, in these emerging care delivery models. So.
The next question is from Erica Smith. Has any research been done to determine determine best practices for user interface design for mHealth apps based on target users? For example, assessing the degree to which the interface affects patients' ability to interact with apps and enter complete and accurate data.
Yeah, there's a lot being researched around usability testing and inclusive design too. I wouldn't say this originated from within healthcare, but all of the major software companies and so forth have been using techniques to create good products that consumers will buy, and that knowledge and those processes we need to use within healthcare too. So yes, there is research going on how to design these apps, how to design these technologies to be useful for patients. I wouldn't say there's probably been enough yet, and for anybody who has used a electronic health record and you've gotten frustrated with it, it's probably because there wasn't a lot of research around usability, around design. But yeah, there is a lot going on right now.
Great. We have many more questions, 3 more. The next one is from Patricia. She said, I recently read an article on a small study in which mobile phones were used to reinforce skills learned in a group therapy. They were not sent daily for the duration of the group. Do you have any recommendations for the use of technology in the psychiatric population?
I don't have much specific for that population because I haven't done a lot of work for it. What I would do is I would, go and honestly, I use Google Scholar more than anything else. And a lot of this is probably published in the JMIR journals. And I think they have one around mental health specifically. But to your point, the message frequency and the message delivery should be tailored for the patient population. So for weight loss, what we had figured out is that people need they would like messages every day at about 8 a.m. And the reason why is for weight loss behaviors, that's when people start their day. So if you send it at 2 p.m., it might be too late. Someone may have, done something, or they may have maybe already ate something that may have thrown them off. Anyways, this is all just to say that, to your point, yeah, we do need to tailor these for the population.
Patricia, I think you have a follow-up comment regarding the response from Dr. Shaw. Would you like to just speak up with about your question directly with Dr. Shaw?
Yes, sorry. So I was just wondering if there was, what part of the technology would be reimbursable, because sometimes to get the institution to buy into them, you have to kind of promote how it's going to benefit or offset the cost of that.
Great question. We are trying to figure this out. So with the last trial that I had described to you, where patients are either receiving this nurse-led telehealth with the pharmacist, in that case, that data from the devices gets pulled into our electronic health record. Legally, I've essentially told them that a nurse is going to be viewing this. So if we do see like trends in like blood sugar or blood pressure that are really high, the nurse will be monitoring them, right? And we're not being reimbursed for this because it's a funded trial, but we will match this up with potential reimbursement mechanisms to deliver telehealth, that piece. But for the other group, for people that we just give them devices, technically I can't pull that data back into our electronic health record right now, because we don't completely know what we're going to do with it. If, say, it does show that the patients are getting worse and we're getting this data, but who's going to look at it? Like, we don't have anybody to look at these data. We have negotiated with the clinics here to hire the nurses for the telehealth, but we haven't figured that out yet, right? Is it okay for people just to send data into the health system and it's just normal, standard of care? I don't know. We still have a lot to learn. So.
Great. Two more questions, and we are good on time, so we should be able to finish all the questions. The next one is from Meg Baxillo. What type of safeguards have you had or Duke put into place for patient privacy? Data is being used for every day by third-party companies. How do we protect our patients in this environment?
Ooh, I feel like I deal with this almost every day now in my life. Security and privacy. First of all, it's complicated. It depends on the devices and the data and where they are coming from. So how I think about it is, before data come into our healthcare environment that requires HIPAA-based regulations, we have a lot more freedom. So if it's like consumer-based devices like Fitbit, Garmin, or maybe something like that, as a consumer, you can make that own decision to give that data to these companies. So that would be one model. And so we have to inform people that their data might be going to these other companies. We have to explain to them what those risks are. For our trials, we actually give them fake names, and we give them fake and also. And we give them these fake email addresses too. But once the data come into our health system, it's more protected, and it's actually it's more difficult to send it back to them. So that the data sits within protected firewalls. Some things we do is we don't aggregate the data outside of the system, so that people can't pull it together to make their own insight. We also have legal contracts with some companies in which they might aggregate the data for us, and they can't sell it, right? And so we have a lot of these different conversations with what are appropriate companies to use or not. Are they going to sell the data or not? And these are conversations that we have with the privacy office, the security office, and we essentially map it out as a data model. And where we can't protect it, we have to inform people, which is hard. I mean, having to explain this stuff to patients is very challenging. I mean, it's hard enough for me to explain it to myself. That's probably a long-winded answer, and we could talk about this pretty much all day long.
Great, thank you. So I think this will be the last question from Dr. Susan Grinsley. In diabetes in particular, the continuous glucose monitors have the potential to improve overall health outcomes. How do we move beyond the obstacles imposed by health insurance, which make it difficult to prescribe our underserved population?
Well, I can comment on the continuous glucose monitors. This was a conversation I had this week with our health system is, how can we begin to pull in data from these monitors into the electronic health record, which is a lot of data, right? So the data is growing, and right, we have to figure out what we're going to do with it. So we are in conversations about that, because we are likely to see these be used a lot more. No one wants to poke their finger. It's not fun. In terms of working with health insurance companies, that's a bit beyond my expertise and my stuff. This is why it's really important to team up with people who work within a policy and things like that. I guess the only thing I can say about that is we need to show health insurance companies, we need to show them outcomes that these devices and these tools can help improve a patient outcome. So in that last trial that I showed you, perhaps if we have great results that will give us, that will, allow people to go to the different insurance companies to hopefully persuade them to be able to do reimbursement. But